good afternoon. I'm Lisa Goodman. I'm with the St. Charles Communications and Marketing team, and it is my great pleasure to welcome you to today's Doc Talk. Movember, it's about more than just mustaches. November is also called Movember, a month when global fundraisers focus on the important issues of men's health, including prostate cancer. So joining us today are doctors Michael Wahl and Cora Calomeni from the St. Charles Cancer Center, who are going to talk about the latest research and advancements in the treatment of prostate cancer, and also talk too about the importance of screening and early detection and lifestyle changes that you can make to reduce your risk for this disease. And just a little bit about our presenters today. Dr. Michael Wahl is a radiation oncologist at St. Charles Cancer Center. He received his bachelor's degree in physics from Harvard University before entering medical school at the University of California, San Francisco. He also completed his radiation oncology residency there. And an oncologist at our cancer center, Dr. Cora Calomeni, has a specialized interest in cancer genetics. She received her bachelor's degree in chemistry and biology from Beaver College in Pennsylvania and attended medical school at the University of Pennsylvania. She completed her internal medicine residency training at SUNY-Upstate Medical Center in Syracuse, New York, and continued there with a fellowship in oncology. So it is my great pleasure now to turn the time over to Dr. Michael Wahl.
All right, thanks for the introduction, Lisa, and thanks everybody for joining. As Lisa said, I'm a radiation oncologist here at the Cancer Center. That means that my job is to treat all kinds of cancers with radiation, but one of the most common cancers that we treat with radiation is prostate cancer. So I'll be giving an update over several areas in the world of prostate cancer, focusing on new developments in both how we screen and how we treat prostate cancer. So here's the outline for my talk. We're going to cover a lot of ground in a short period of time, so this may feel like a bit like drinking from a fire hose, but bear with me, it all does tie together here, and we'll have time at the end for questions if there's any topics that folks would like to delve into a little bit deeper. So I'll be spending the bulk of the time actually talking about prostate cancer screening. This has been something that's been in the news quite a bit over the last decade or so, and a source of a significant amount of controversy. So I want to go into some background about that controversy and where things stand now in terms of screening. I'll also talk about developments in what we call risk stratification, which is basically finding the right treatment for the right patient. And there's been a lot of developments in the last decade or so in that area as well. And finally, I'll touch on some of the more technical advances in how we actually treat prostate cancer for those who undergo treatment. So just a bit of background before we get into things. Prostate cancer is the most common male cancer in the United States. It accounts for about 25% of all new cancer diagnoses every year. But despite that, it only accounts for 11% of annual deaths from cancer amongst men. And so why is that? Why is this the most common cancer diagnosed, but not the most common cause of death from cancer? The short answer is that prostate cancer is highly curable if it's caught early and treated appropriately. Once it's spread out from the prostate to other parts of the body, it does eventually lead to significant mortality. But one of the reasons why most cancers are treated with, or most prostate cancers are treated with an eventual cure, is that we have a screening technique to detect these cancers early before they spread. So this leads into talking about prostate cancer screening and some of the controversy that surrounded it recently. So just to give a brief background on how we screen for prostate cancer, we do this by taking a blood test measuring something called the prostate-specific antigen. This is a protein that's produced by cells within the prostate. Normal prostate produces a low level of this prostate-specific antigen, or PSA. But when a cancer develops within the prostate gland, the PSA goes up. That can be detected with a blood test, and it prompts further workup to diagnose a cancer. So this became widespread in the United States for routine screening around the late 80s, early 1990s. And as we can see on the plots here on the right, right around the time that PSA screening became common, we saw a large spike in the incidence of prostate cancer. Many men were coming in and getting their PSAs checked for the first time, and many men got diagnosed with prostate cancer right around that time. That spike went down a little bit, but since then we've seen a higher incidence of prostate cancer every year compared to the era before we did routine screening. So we've seen an increased incidence of diagnosis of cancer over that time. The question is, what has that done to mortality from prostate cancer? Has that resulted in fewer deaths from prostate cancer? So if you look at the red line on the plot here, we can see that there's really been a very mild decrease in mortality over the time that we've detected more cancers through screening. So this really begs the question, if we're detecting a lot of new cancers but not significantly affecting mortality, do men really benefit from this screening? And more specifically, are we detecting prostate cancers that maybe never needed treatment in the first place? Many prostate cancers are very indolent. They may never progress to the point where they spread outside of the prostate and threaten a man's life. And this is supported by some autopsy studies that have been done. And it turns out that if you take men over the age of 70 who die of other causes and check their prostate, about 70% of them have some kind of prostate cancer present at the time of their death. So this has led to the adage that you may have heard that men die with prostate cancer, not of prostate cancer, meaning that even if they have a cancer diagnosis, it's not the cause of their death. And this begs the question, how many men actually benefit from going through the process of screening and treating for prostate cancer? So in the background of that question, there were a couple of really landmark large studies that came out in the late aughts and early 2010s to address this question. These were both randomized trials where half of the men on the study received prostate cancer screening with PSAs, and the other half did not. One study in the US screened about 75,000 patients. Another study in Europe was 180,000 patients. So these were very large studies to try to get to the bottom of this question of the extent of benefit from PSA screening. So here are the results from the US study. On the left, we see a plot showing the number of new cancer diagnoses as a function of time since the trial started. And you can see, as you would expect, that patients who were getting screened for prostate cancer, we were diagnosing more prostate cancer. And of course, that shouldn't be a surprise. On the right is comparing the mortality from prostate cancer between the two groups. And here we actually didn't see any difference. So men who underwent PSA screening did not see any reduction in mortality or death from prostate cancer looking 10 years after the trial started. So that appears to be a very negative result for the idea of PSA screening, but there are a couple of pretty significant caveats with this study. The first is that this was a heavily pre-screened population for cancer, meaning that many of the men enrolled on the study had already gotten PSAs. So that, that means that they were much less likely to find a new cancer on the study. The other is that there was a lot of crossover on this study. About half of the patients who were assigned to not undergo screening decided to get screening over the course of the study, and so that complicates the results here. There was a second study done in Europe in a largely unscreened population, which actually did show a benefit to PSA screening. And specifically, there was a 20% reduction in the risk of death from prostate cancer in patients who underwent screening on the study. Now, that sounds like a large reduction, but what really matters is what the absolute reduction in death of prostate cancer. And as you can see from the plot here, the risk of dying from prostate cancer, even in the folks not getting screening, was pretty low, under 1%. And so with 11 years of follow-up, you would have to screen about 1,000 patients just to prevent one death from prostate cancer. Of those 1,000 patients, 37 would require treatment. So you would have to treat 37 patients, again, to prevent one death from prostate cancer. And so despite there being a benefit here, there remains questions as to whether this small benefit in preventing prostate cancer death is worth the potential risks and the potential side effects from treatment for your prostate cancer. So in the context of these studies, a very influential organization called the U.S. Preventative Services Task Force came out with a recommendation in 2012, actually recommending against routine screening for prostate cancer. So they gave it a grade D recommendation, which means that they felt there was evidence that the harms from prostate cancer screening outweighed any benefits from screening. This generated a lot of press. Many of you may have seen this at the time, a lot of controversy and strong feelings on both sides, whether this was an appropriate recommendation to make or not. But based on that recommendation, practice patterns did change throughout the United States. We did see a reduction in the amount of routine screening that was being performed, and that actually led to fewer diagnoses of prostate cancer than what we'd seen before those recommendations came out. At the same time, and you can see this in the plot on the right here, we saw an uptick in the number of patients who were coming in with not local disease that can be cured, but regional, meaning spread in the pelvis, or distant disease spread to other parts of the body, which generally can't be cured. And so we really did see the effects of these recommendations and a turn away from PSA screening, unfortunately, to the detriment of men who presented with these more advanced stage disease. After the task force recommendation came out, we actually saw some more extended follow-up from the European study, the one that did show a benefit to PSA screening, which basically showed that with a longer period of time, we see more of a benefit from screening. So I'd mentioned that at 11 years, you would have to screen about 1,000 patients to prevent one death. If you extend that to 16 years, that number gets cut in half to about 500. Similarly, the number of patients we would have to treat to prevent a death went from 37 down to 18. And so, that gets to the point where I think most men would be happy to, undergo treatment, knowing that there was a 1 in 18 chance that it would prevent their death from prostate cancer down the road. And this also highlights that the benefit from PSA screening really takes time to see. So when you get a PSA test today, the goal is to prevent death from prostate cancer 10, 15, 20 years down the road. So there's really a delayed benefit when we undergo screening. So after seeing the real world effects of their recommendations, and also after this updated data came out, the task force did a bit of a mea culpa here and actually changed their recommendation. And now giving it a C score, meaning that the risks and the benefits of PSA screening needed to be weighed carefully for patients in the appropriate age group. So I want to take a step back and just think about the big picture of what the risk-benefit ratio is for patients undergoing screening for prostate cancer. So, the concern through all this has been that, we are diagnosing too many prostate cancers and over-treating prostate cancer, and potentially treating cancers that would never require treatment. But the bottom line is that there's no harm associated with receiving a prostate cancer diagnosis. The PSA is just a blood test. A biopsy is a very benign procedure with a very low risk of any complications. The risks from having a prostate cancer come from the treatment of the prostate cancer. And so overdiagnosis, I think, is not the problem here. The problem here is that, historically, we've overtreated patients with prostate cancer. And so rather than putting our heads in the sand and not finding the cancers in the first place, I think it's much more important to very carefully select the patients that undergo treatment in order to minimize the risk of harm from the treatment, and also work very hard to reduce the side effects from the treatment itself for those that do require treatment. So in order to do that, we undergo what's called a risk stratification. That means that we take patients with a diagnosis of prostate cancer, and instead of giving them a one-size-fits-all treatment, we look at the risk level of their cancer. And we do this using a few different factors. One, of course, is the PSA. Higher PSA means higher risk cancer. One is what we call the T stage. That is how much of the prostate gland is taken up with cancer. And a third is what we call the Gleason score. That's a measure of how aggressive the cancer appears under the microscope when we look at the tissue from the biopsy. And using these three factors, we now put patients into three risk categories: low, intermediate, and high risk. The idea here is that we can identify patients who may not need treatment for their cancer at all, and also find patients who are at higher risk of progression of their cancer who may benefit from more aggressive treatment. So this leads into the concept of active surveillance, which is founded on the idea that not all prostate cancers need treatment. So for patients who fall into this low risk category, we now monitor them with regular PSAs and periodic biopsies. And we only treat these patients if they show signs of progression of their cancer. So if their PSA rises, if their biopsies show that the cancer is becoming more aggressive or spreading more extensively throughout the prostate, that's when we recommend treatment rather than for all patients with low risk disease. This has been studied in multiple large trials and shown to have no effect on long-term survival from cancer, meaning that we're not losing a window for cure for any of these patients who undergo active surveillance. And with about 10 years of follow-up, we find that only about 50% of patients need treatment during that time frame. So by undergoing active surveillance, we're able to spare a lot of patients from any potential side effects from treatment. This is looking at one of the largest studies to examine active surveillance. It found that at 10 years from the start of surveillance, the prostate cancer specific survival, meaning the risk of dying from prostate cancer, was about 1%, and not different compared to patients who underwent treatment as soon as they got their diagnosis. So active surveillance has really become standard of care for patients with low risk disease. And we've seen a real increase in the amount of people who get active surveillance over time, as people, I think, become more comfortable with the idea of not immediately jumping into treatment. And now it's what's recommended and what's pursued for a majority of patients with low risk disease. We are in the process of trying to improve how we identify patients for active surveillance. The standard way is to use those clinical factors that I mentioned before, but there are some new genetic tests out there that help refine this even more. I'm showing one here called the Decipher Score, which actually takes genetic material from the prostate cancer tissue and looks at 22 genes to determine the risk of progression of the cancer. And this has been shown to give us additional information beyond what we knew already from the clinical data to really identify the best candidates for undergoing active surveillance and not pursuing treatment, and also increase the confidence of both the physicians and the patients that this would be a safe approach. So the pendulum in terms of prostate cancer screening has really swung back and forth a lot over the last 10 to 15 years. We went from a situation where we essentially screened everybody and where we're much less discriminating with who underwent treatment for prostate cancer, and probably exposed a lot of men to more treatment than was needed. After studies calling into question the benefit of screening, the pendulum swung the other direction, and we saw a lot less screening in our population as a result. And now I'd like to think we've reached kind of a nice middle ground where we're not sticking our heads in the sand and avoiding finding prostate cancers, but we're much more judicious about who we offer treatment to and the kind of treatment that we offer, in order to minimize any potential harm from overtreatment of prostate cancer. So I've just got a couple of minutes left, and I want to briefly run through some recent advances in how we actually go about treating prostate cancer. The main treatment for men who have localized prostate cancer is either surgery or radiation, and there's been really significant advances in both of these areas. So of course, I'm a radiation oncologist. I'll focus most on the radiation advances, and they've come in really two forms. So first of all, we're getting much better and much more accurate in how we deliver the radiation to treat the cancer. 15 years ago, most patients were treated with something called 3D radiation. This was a very primitive technique where we basically shined a beam in from the front and the back and from the two sides. They met in the area of the prostate to deliver the radiation, but it was not a very precise way of doing it. More recently, a technique called IMRT was developed. This used a number of beams shining in from different directions that were very carefully sculpted to focus the radiation dose on the prostate gland itself and to avoid a high dose of radiation to any surrounding tissue. And more recently than that, a technique has come out called stereotactic radiation, or SBRT, which uses very precise technology to deliver the radiation in a very focused way on the prostate itself. And as we've become more precise with our radiation, we've seen a significant decrease in side effects from treatment. At the same time, treatments become much more convenient for patients. In the olden days, patients would have to go daily radiation for about 9 weeks. That was reduced to about 5 weeks, as we found that with these more accurate techniques, we could deliver a higher dose of radiation each day over a shorter period of time. And now with SBRT, we can deliver an entire course of treatment for prostate cancer with just 5 treatments. And so the burden to men undergoing treatment is really significantly reduced with this technological development. I won't go into too many details about advances in the realm of surgery, but one thing that has been a significant advancement is the development of robotic surgery. So you may have heard about this. This is a technology where instead of standing over the patient and performing the surgery manually, surgeons actually sit at these consoles and move robotic arms to actually perform the surgery to remove the prostate. And this is generally a much less invasive procedure, and recovery times are shorter from surgery. So just to go over some take-home points from the discussion, PSA, despite all the controversy, remains a very valuable screening tool for prostate cancer. It's been shown both in studies and in the real world to reduce mortality from prostate cancer and reduce the risk of diagnosis of late-stage prostate cancer. So I still encourage men to undergo PSA screening. And this is recommended for men in the ages from 50 to 75 who don't have any life-limiting medical conditions. So that means that if your life expectancy would be 10 years or more, you would likely benefit from PSA screening. That being said, overtreatment of prostate cancer does remain a concern. And the key is to be very careful once you have a prostate cancer diagnosis of whether or not to pursue treatment. And so selecting the right patients for the right treatment, including patients for whom treatment may not be needed, is really key here to maximizing the benefits from screening and treatment for prostate cancer while minimizing the potential risks. At the same time, every year we have more developments in terms of the technology of treating prostate cancer. So it becomes easier and with less risk of side effects every year that passes. So with that, I will turn it over to Dr. Calomeni, who I think is on the line with us, and she's going to be discussing recent developments in hereditary prostate cancer. And Dr. Calomeni, oh.
I know she was having some technical difficulties getting on with us, so we'll give it another second or two here, and then maybe we can launch into some of the questions we've been getting throughout your presentation, Dr. Wahl.
So here it says the host unmuted me. My muting is being controlled by you all.
There we go. We see you and hear you, Dr. Calomeni.
Very good. And Dr. Wahl, I understand that you are the one who is controlling my slides.
That's right. So I'll try to keep up with you, but if you want me to advance, just say the word.
Yeah, I'll just mention that. And so I really enjoyed Dr. Wahl's presentation, and my part of the presentation, I think, dovetails perfectly in with what Dr. Wahl was talking about. So I do hereditary counseling and testing to identify individuals who are at higher than average population risk for development of cancer. And so my two takeaway points for this discussion is, number one, to encourage the appropriate gentleman to undergo genetic testing. I've been doing genetic counseling and testing for, gosh, almost 2 decades now. Yeah, even longer. And I must say that I probably test about 70 plus women to every one man. And so this genetic testing is very germane to our topic here of prostate cancer risk. And so Dr. Wahl in his discussion talked about low risk, intermediate risk, and high risk. So next slide. So in the average population of men, the probability of a man born in the US of getting prostate cancer is 14%. But yeah, it's going on its own here. But the percentage of men who inherited a gene that predisposed to that prostate cancer is about 5 to 10%. When you look at the probability of all women born in the US of developing breast cancer, only 5 to 10% of those women inherited a gene that predisposes to breast cancer. And so those women, a lot of women are aware of genes that will predispose to their risk. They do have a lot of places, including St. Charles, has a high-risk clinic for those individuals at elevated risk. And it is coming down the pike. In some places, it is already going on. I do hope that in the future, we will have a high-risk prostate cancer clinic as well. And that is my second point that I wanted to make, is I think that we would benefit from a high-risk prostate cancer clinic. Next slide. So In a study done by Dr. Pritchard, his name is on the right-hand side there. It got moved somehow. He tested patient or individuals that were diagnosed with prostate cancer and looked at what genes were identified. So on the left-hand side, it is in descending order of frequency, and right at the top is BRCA2. BRCA2 is associated with breast cancer and ovarian cancer. It is one of the most frequently seen genes in the population that predispose to increased rates of cancer. And it turns out that in this study, this particular gene was found in the highest proportion of cases at 5.7%. And the important factor is that it is also associated with the most aggressive forms of prostate cancer. Below that is CHEK2, which is also a breast cancer gene. In place number 3 is ATM, which is also a breast cancer gene. The ATM gene is associated as well with an aggressive form of prostate cancer that likely requires heightened screening. Below that, MMR is actually a group of 5 genes that are associated with Lynch syndrome. The reason that these genes are important is that if a gentleman inherited one of the Lynch syndrome genes and developed prostate cancer and had advanced disease, there would be treatment modalities available to him that are not available for the average population group. The next 2 genes are also colon cancer genes, but then right after that is BRCA2. We're going to skip the next gene, but the other 3 genes on the right side of the screen are all breast cancer genes. The gene that I skipped, the HOXB13, is the only prostate cancer only gene that has been identified thus far. And at least at this time, this particular gene does not appear to be associated with a more aggressive form of prostate cancer, but it certainly informs the risk of developing prostate cancer. And so not too long ago, I had a young woman come in because her mother had a very strong family history of breast cancer and she wanted to be tested. I tested her and it turned out that she tested positive for the HOXB13 gene. Her father happened to have brought her in as emotional support, and he was waiting for her in the car. And I asked if he would be interested in coming in so I can talk to him about undergoing testing. Because when you have, when an individual inherits a gene, you have to determine which side of the family the gene came from. Her father was agreeable to being tested to know whether the gene came from his side of the family or the mother's side of the family. And he turned out to be positive for the gene. So that's where she inherited it from. Now, she is not going to inherit any cancers related to that gene, but the father's family history was very highly impressive in that almost every male in the family was diagnosed with prostate cancer. And so not all genes have, the vast majority of genes, if you inherit the gene, It does not mean necessarily that you're going to get cancer. It just means that your risk is higher than the average population risk, and the average population risk is 14%. But certainly this gentleman should undergo screening, and he should undergo screening anyway, just based on his family history. Next slide. So if you can click. Why do we want to identify? And hopefully you got a glimpse of that as I was going through the genes. Some of the genes associated with prostate cancer is associated with high risk categories. So that's BRCA1, BRCA2, ATM. And there are clinical trials underway at the present time to try to see if any of the other genes that have a higher than average probability of developing prostate cancer affects the frequency of getting the disease. One thing that was certainly identified in one of the clinical trials is that men that inherit the BRCA2 gene should be screened earlier. So Dr. Wahl was talking about screening starting at the age of 50. For men with BRCA2 gene, it is being recommended, and BRCA1 for that matter, that they start their prostate cancer screening at the age of 40, not 50. And instead of having the screening maybe every other year, have their screening performed annually. And that if their PSA is 3 or above, that they should have prostate biopsies. Click, please. And so we're talking about risk stratification, which Dr. Wahl explained in his discussion. So some of these genes do not increase the aggressiveness of the disease. So those individuals can be monitored, but knowing that you inherited the gene means that the probability of you getting prostate cancer is likely higher than the average population. And so you should be monitored, even though it's the same risk as the average population, as Dr. Wahl outlined. But if you inherited one of those genes that predisposed to a much more aggressive tumor, your prostate cancer screening would be modified. Next. And then also, as I already mentioned about the MMR genes, there are different treatments, and certainly for the BRCA genes. So if one inherited a prostate cancer that is related to BRCA1 or BRCA2, there may be preventions, early interventions. There's a lot of studies going on in this group to see how the outcomes for these individuals can be improved. Next slide. Next slide. Next slide. This slide, I just wanted people to understand that all of these genes, the men inherit the genes and they pass those genes on to their children. And for all of these genes, these are dominant genes, so each child has a 50-50 probability of inheriting the gene. For the BRCA genes, the women develop cancers at a much more frequent rate than the men. But the importance to the men is having an aggressive form of prostate cancer that they need to modify their screening. Next. So for the high-risk clinic, these are the NCCN guidelines. And so this is what I'm hoping will occur at some point at St. Charles. Next is men with prostate cancer. Any man with prostate cancer that's spread to other parts of the body is eligible for genetic screening. Next. Men with early prostate biopsies that show intraductal or high or very high risk group is eligible for genetic testing. Next. Family history. So breast cancer, when you looked at that slide, almost all of the genes associated with prostate cancer are also associated with breast cancer. Ovarian cancer, pancreatic cancer is also a cancer associated with BRCA2 that would predispose to aggressive forms of prostate cancer. And then a family member with a diagnosis of prostate cancer that includes those criteria above. Next. And then 2 or more blood relatives with breast or prostate cancer, regardless of age. Next. And then Ashkenazi Jewish ancestry. So being of Ashkenazi Jewish descent and having prostate cancer automatically qualifies you, and it doesn't make any difference the type of prostate cancer. The reason for that is in the Ashkenazim, the frequency of the BRCA mutations is many times higher than that of the average population. And so these are families and individuals that should be monitored if they're positive for the gene. So that's the conclusion of my talk. And if people have questions, just feel free.
Great. Well, thank you, Dr. Calomeni and Dr. Wahl. Wonderful presentations. And we have received a number of questions that have come in on our Facebook and YouTube social media channels. The first question, and Dr. Wahl or Dr. Calomeni, feel free to jump in and answer these depending on your expertise, but is radiation required after a prostatectomy or prostatectomy, excuse me? So does it depend on the individual?
Yeah, I can field that question. So we don't routinely do radiation after prostate surgery or prostatectomy. We generally only treat patients with radiation after surgery if their PSA does not go away after surgery, or if it rises after a period of time of being low. And so the risk of needing radiation after surgery depends on which risk group you're in. So low risk patients have a pretty high chance of undergoing prostatectomy and not needing any further treatment. As you get up into intermediate and especially higher risk patients, we see a higher and higher percentage of patients who do need radiation after their surgery.
Great. And how do I get screened for prostate cancer? One of our viewer asks, do I just make an appointment with my primary care provider? Do I call the cancer center directly? What's the pathway for getting screened?
That's a really good question. So, you know, as I think the complexity of the discussion suggests, it's a really complex question about whether or not to undergo screening, and it's one that's best performed with your primary care physician. So my recommendation would be to meet with your primary care physician to discuss the risks and benefits of screening. They know your health history. They know if you would be expected to live long enough to benefit from treatment for your prostate cancer. And so rather than just, you know, getting a blood test ordered and having your PSA checked, it's best to have that discussion so you go into the process eyes wide open.
Great.
I would like to add, if I may, is that it's usually through the primary care provider, but I also encourage people to be a bit more proactive. So in those families that have a history of breast cancer or a family member with a known mutation, that when you go in and talk to your primary care provider, please, and hopefully they have that information, but they may not. And if you do have the family history of breast cancer, pancreatic cancer, metastatic prostate cancer, please be proactive about it. Thinking about prostate cancer screening and genetic testing. Now, I must say, over the years, I have been seeing that more and more primary care providers are more knowledgeable than they have been in the past. And I think that that's a reason as well that I am seeing a bit more men lately undergoing screening.
Great. Thank you for that, Dr. Calomeni. One of the themes in the presentation today is that really the problem is more about overtreatment than it is overdiagnosis. So let's say I am diagnosed with prostate cancer and it turns out I'm indeed a good candidate for treatment. Post-prostate cancer treatment, what will I be limited, or what ways will I be limited? So in other words, how will my life change after prostate cancer and after treatment?
So that's a good question, and we could probably devote an entire hour just to addressing the risks of side effects from either surgery or radiation for prostate cancer. Suffice to say that most men maintain a good quality of life after they undergo primary treatment for their prostate cancer. There are possible side effects, of course, both with radiation and surgery. But the risk of any significant long-term side effect is relatively low. It's on the order of 10% or less. And so this goes back to some of those never needed to treat statistics that I provided. With the longer follow-up from one of those studies, I mentioned that something like, we need to treat 18 patients to prevent one prostate cancer death. So that 1 in 18 is probably on the order of the number of men who would, suffer any significant long-term side effect from treatment. And so, we're weighing a small chance of significant late effects from the treatment versus that benefit in terms of preventing that one death.
Great. What should men do to ensure they maintain good prostate health through their lives? Are there lifestyle choices that they can make that are going to mitigate their risk of prostate cancer? Or is it genetic and the cards are played and it doesn't have a whole lot to do with lifestyle? So perhaps you both want to contribute to that. I know Dr. Calamini probably has thoughts from a geneticist perspective.
Well, as far as prevention of any type of cancer, essentially it's healthy lifestyle. And what appears to be the biggest factor is exercise. So I tell people physical activity, physical activity, physical activity. It doesn't mean that you have to have aggressive, you don't have to go out and run marathons. It just means walking every day briskly for at least a half hour. So there have been numerous studies that have shown that regardless of a person's weight, so even people with obesity that we know is a risk factor for cancer, active obese people are less likely to get cancer than sedentary obese people. There is some inklings as to why this is, but that's probably number one. But yes, genetics does play a role. But again, when you look at all individuals with prostate cancer, only 5 to 10% of them have a gene. And so, it's the interplay of all those things.
Right. Next question. Are there many new medications for those being treated for metastatic prostate cancer? My husband is being treated, but we'd like to know if there are other options and if indeed this medication stops working. So in other words, they're being treated for metastatic prostate cancer. Are there more options available?
Yeah, so the short answer is yes. And I didn't get into this in my talk at all, but one of the areas where we've seen the most changes in the world of prostate cancer is the number of treatment options available for men with metastatic disease. And it seems that every year or so, there's a new drug or a new indication that comes on the market for treating men with metastatic disease. We think of this as kind of a toolbox, and each time one medication stops working, there's other things we can pull out to try to keep the prostate cancer under control. And every year there are new things that are coming out.
Okay, great. Could prostate cancer treatment affect my ability to have children? If so, should I talk with a fertility specialist before cancer treatment begins?
So that's a really good question. It's one that we don't typically have to address with patients, because patients generally are diagnosed with prostate cancer later in life, after they've had their children and have no desire for more children. But either form of treatment, surgery or radiation, certainly would affect your ability to have children. And so if that's on the table, and if you're unlucky enough to be diagnosed with prostate cancer at an age where you're still looking at having children, I definitely recommend discussion with a fertility specialist about how to navigate that.
Well, the only thing I would add there is if the person asking this question has been diagnosed with prostate cancer at a young age, meaning 40, et cetera, it could be because there is a gene that predisposed to that malignancy. Now, it's not 100%, but it is a reason to look into the genetics in that situation, if that is the case.
Great point. Thank you, Dr. Calamini. Well, I have difficulty controlling my bladder or bowel function after treatment. So again, assuming you're a good candidate for treatment and that's appropriate, is that potentially one of the outcomes of treatment?
So that is a potential side effect, and I'll get into that in a little bit more detail. Again, there's two types of treatment for prostate cancer, surgery or radiation. Surgery can affect your urinary function by causing incontinence or loss of the ability to hold your urine. Most patients are able to largely regain their continence after surgery, but some men do need to wear pads long-term because of that. The surgery itself does not affect your bowel function, so that's not a concern there. On the radiation side, with radiation, the risk is not incontinence from treatment, but what we call irritative symptoms. Things like frequency, urgency, getting up more at night to urinate. The radiation can affect your bowel function as well, but the risk of any long-term bowel side effects from the radiation is very, very low, under 5%.
Great. It looks like we have time for just two more questions. The first one, what type of prostate cancer screening schedule do you recommend for me, a 45-year-old male? So I'm sure there are going to be lots of questions you would ask someone like this to determine their risk and decide what the appropriate screening schedule is. But Dr. Wahl or Dr. Calamini, how would you answer that question?
Well, what I will say is I was reviewing the prostate cancer screening guidelines, and actually in the NCCN guidelines, they talked about starting prostate cancer screening at the age of 45. Now, as I stated in my talk, that for BRCA mutation, it's going to be 40, and individuals with normal PSA levels at 45, they are talking about repeating the PSA every 2 to 3 years is what I saw in the guidelines. Dr. Wahl, do you?
Yeah, I think we tend to follow NCCN guidelines. There are, different professional organizations out there that give slightly different guidelines in terms of age to start and end treat screening as well as frequency. Again, I think it's a conversation with your primary care physician, but typically starting 45 to 50 and checking at least every couple of years.
Okay, great. Final question. Do you know of any support groups available for patients with prostate cancer?
I would think that there definitely are. How they can get in touch with that, people can contact the Cancer Center. So there is and I would just contact the Cancer Center because there are people there that know about the support groups. You could probably also go online about prostate cancer and just Google support groups. But the American Cancer Society would know about support groups as well.
Okay, very good. Well, that was our last question. So I want to thank everyone who joined us today. And thank you, Dr. Wahl and Dr. Calomeni, for sharing your time and your expertise. It was very informative. Just as a reminder, we did record this presentation and we will be making it available on the St. Charles website. So please go there and find it and feel free to share it if you know others who need this information. And finally, we hope that you'll join us again in January when we have our next presentation on concussions. So again, thank you very much. Happy holidays to you and yours, and we'll see you again here soon. Thank you.